Dr. David Spiegel and his team of researchers found that depression can mean faster rates of cancer progression. He presented his findings at the annual meeting of the American Psychiatric Association.
We found that 15 of 24 studies show a relationship between depression and the rate of cancer progression. There was less relationship to incidence, but a strong relationship to disease progression. And recently in the Journal of Clinical Oncology, Janine Giese-Davis and I published a study showing that the course of depression over a year among women with established metastatic breast cancer significantly predicts overall mortality. So we did here a median split, and you see that those whose depression was getting worse during this baseline year here died significantly sooner than those whose depression was getting better. This suggests that depression is the same kind of risk factor for mortality in cancer that it is in cardiovascular disease, and yet we're much less inclined to think of depression as an important and treatable factor in depression than heart disease. And it's important to note that this relationship to depression was independent of all the other known risk factors: estrogen receptor status, HER2 status, disease-free interval, age of diagnosis. And so we encourage patients to express rather than suppress emotion. Give vent to your anger, fear, and sadness, and you begin to be able to move beyond it. We actually found in a randomized trial that we significantly changed their method of managing affect. So they tended to be less suppressive of their anger, fear, and sadness over time compared to the controls who got more suppressive. And I think this is the first psychotherapy trial that demonstrates a change in emotion management, and this change was correlated with their improvement in overall anxiety and depression.
Dr. Spiegel encouraged psychiatrists to screen for depression in breast cancer patients and to treat it aggressively.
Very often, depression is underdiagnosed in cancer patients, and the reason is that many of the symptoms of depression could be misattributed to being symptoms of cancer and its treatment. So, of course, she feels hopeless. She's got a bad prognosis. Of course, she isn't eating well. She's getting chemotherapy. She's nauseated. Of course, she isn't sleeping well. She's worried about her illness. So, of course, she feels helpless. She's got to deal with all this medical treatment. So you could take someone who has all the symptoms of major depression and conclude that they don't have depression. They're just coping, with some problems with advancing cancer. And so I think it's important for psychiatrists in particular to play this role of saying, until proven otherwise, this patient may have both diseases, and there's things I can do to help them with their depression. So be aggressive about helping them both psychotherapeutically and psychopharmacologically in dealing with depression, and view it as an important part of the overall cancer treatment.
With Clinical Psychiatry News, this is Frances Correa.